Hi, Terry Schoenfeld for UAB School of Medicine. Residual confounding is always a potential explanation for findings seen in observational studies. In this video, I'll discuss what residual confounding is and how you might detect it in observational studies.
So as a reminder, confounding is distortion of the association between an exposure and an outcome by a third factor. In this case, we're going to consider that third factor to be smoking. For smoking to be a confounder, it has to be associated with both cardiovascular disease and hormone replacement therapy, but not just be a link in the causal chain. And it really is associated with cardiovascular disease. We certainly know smokers have greater cardiovascular disease risk, and the question will be, is it associated with hormone replacement therapy? And you could postulate that women who use hormones or don't might have differential rates of smoking. So it seems like it's a decent confounder. The other component of it being a confounder is it has to be unequally distributed amongst hormone users and non-users. And when you look at studies, it tends to be that way. Hormone users tend to smoke less than women who don't. So smoking is a confounding factor. So what is residual confounding? Well, residual confounding is just distorting the association between exposure and outcome because you've incompletely controlled for confounding in either the design or the analysis phase of a study. And the most common cause is that the researchers just didn't collect data on that potential confounders. Now, sometimes it's because they didn't know that something was a potential confounder. We do discover new things as time goes on. But another common reason is that in this day and age, observational studies often use databases that already exist or previous studies that have already been done, and they do an observational study buried within that. And the researchers are dependent on information being present in those databases or in that previous study. And if they're not, you just can't have any information on potential confounder and to control for it. So that's the most common reason for residual confounding. Now this is an example I'll use to demonstrate residual confounding. On the left is the Nurses' Health Study and the demographics from the Nurses' Health Study, which was an observational study. On the right is the demographics of women in the Women's Health Initiative, which was a randomized controlled trial. And I'm just going to highlight some important differences that are related to cardiovascular risk in the women who were never users of hormones and the women who are current users of hormones. And as you can see, the women who are current users have less cardiovascular risk factors and are in general healthier than the women who never use hormones. So the question will have to be is, even if I control for these things that I have measured in this study, if I see a difference in cardiovascular events in the users compared to non-users, I'll always have to wonder, was it related to confounding? That won't be the issue over here in the Women's Health Initiative because randomization was used and it's such a powerful tool to control for confounders. And you can see I highlighted with these red arrows similar risk factors in the Nurses' Health Study. You can see they're very equally distributed in the Women's Health Initiative. And as you'll remember, randomization controls both known and unknown confounders, so I expect everything to be equal in patients in the Women's Health Initiative. So what do we see? Up top here, this is the results from the Nurses' Health Study, and you see a really large reduction, 61% reduction in cardiovascular risk in women who use estrogen and progesterone. A very impressive result, so impressive that it was highly recommended that women get placed on hormone replacement therapy postmenopausally to protect from cardiovascular disease. Researchers even studied this in men to see if it could prevent cardiovascular disease. And we really anticipated the results of the Women's Health Initiative because it was going to be the first randomized controlled trial to study hormone replacement therapy and cardiovascular disease. And when it came out, everyone was surprised. What you saw was a 29% increased risk of cardiovascular disease in women on hormones compared to women on placebo. So a shocking finding that people were scrambling to try to understand, why did we see this difference? So some of the differences could be accounted for how things were done in the study. There were slight differences in the populations in the Women's Health Initiative and Nurses' Health Study. The age at starting hormones was different. The formulations of hormones were a little different. The Nurses' Health Study didn't measure silent MIs. But really what people have really thought was this was mostly going to be an evidence of residual confounding. So if you take a minute and pause the video and look at this table from the Nurses' Health Study and think about what isn't on this table, what is missing that could impact cardiovascular risk. And when you thought about it a little bit, restart the video and you can see some of the things I thought about. So here's some of the things I thought about. There's no real mention of exercise in this, and exercise habits were not measured. Well, you might say, well, body mass index is a good surrogate of that. Well, you can have a low body mass index for a variety of reasons that have nothing to do with exercise. For example, you could have cancer. There's no measurement of cholesterol-lowering drugs. There were cholesterol-lowering drugs at the time of the Nurses' Health Study which lowered cardiovascular risk. There's no mention of ethnicity. And then I put these question marks here because what else could be missing that I'm not thinking of or other people haven't thought of? But this all gets back to probably the differences are related to residual confounding. And one of the things you always need to ask yourself when you see the results of an observational study is, what did the researchers miss? What didn't they control for in this observational study? Is there residual confounding? And the way you really figure that out is using your clinical knowledge. Your knowledge about what impacts disease is what you're going to use to think about when you look at the patient population and what was controlled for by the researchers to figure out, did they do a good job controlling for all potential confounders, or is there still residual confounding?
This video has helped you understand what is meant by residual confounding. Remember, if you have any questions, you can contact me through the course website or through the Contact Me section of my blog. Have a great day.